All right, so I want to welcome everyone. Thank you for attending our panel on quality and safety initiatives and giving you international perspectives. My name is Richard Ehrman. I'll be moderating this session. Let's see if I can figure out how to advance my slides. That would be good. So we have three speakers today. We have Dr. Pedro Ibarra. He's based in Colombia, but he's also very involved with the World Societies of Anesthesiology. So he'll be here and give you Latin American perspectives. We have Professor Wolfgang Buhrer here as well, and he will talk about European initiatives. Helsinki Declaration will be his main topic, and he's the chair of anesthesiology in the Netherlands University Medical Center in Utrecht, and ESA president currently for a few more months, I think. Yeah. Couple of months, so there you go. And of course, we have Dr. Louise Connolly. She's the professor of anesthesiology at the Medical College of Wisconsin and the ASA vice president for professional affairs. So just very briefly, 2 minutes before I hand it to our speakers. So a couple of things we'll be celebrating, of course, the World Anesthesia Day coming up in about a week. There's also other worldwide initiatives. The World Patient Safety Day, many of you are familiar with that. It's celebrated every September, and there's a different theme every year. This year, it's all about the newborn and the child safety. In the past, again, all of these things, even though they're not specific to anesthesia, they're all obviously very relevant. Last year was improving diagnosis for patient safety, and before that, it was really engaging patients for patient safety, so all very relevant. So a lot of things going on a global level as well. I ran into this paper. I said, what was happening? What was state of the art 100 years ago? Exactly, today, but 100 years ago. This was a paper, one of the first issues of Anesthesia Analgesia, and they talked about spinal anesthesia and how blood pressure tends to change a lot. There's a lot of fluctuations, how important it is to measure it more frequently. Just think about that. So I thought that was an interesting paper just to give us a perspective of how we have, gotten. And finally, there are other things going on that are spearheaded by the World Health Organization. Again, this is not focused on anesthesiology, but obviously, if you look at all those pillars, I know it's probably hard to see down there, but all of the things that they talk about, this is a 10-year plan, essentially safety action plan. Things like high reliability systems, right? Thinking about engaging patients, eliminating avoidable harm. So all of these things have relevance to perioperative and peri-procedural setting. So just to kind of give you a more global perspective. So I would like to start with our speakers. I would like to introduce Dr. Barr. Are you ready, or you want to be the first? Oh, you're on the list, so there you go. So I would like to introduce you, and I already said a few words about you. So let me get your slides here. And we'll start with you. There you go. I think that's you.
Okay. Thank you, Richard, for the kind invitation. I'm going to start and talk some of the experiences that we have had in Latin America. I'm currently the chair of the Safety Committee of the Latin American Confederation Societies of Anesthesiology. My conflict of interest, I've been into this business quite a while, and I've been a main author of guidelines in Latin America. I'm going to talk about 4 issues regarding the Latin American scenario in the last couple of years. The first one will be about Mexico's neuraxial deaths, which has been a terrible tragedy that we have faced. The second one will be about Argentina's contaminated fentanyl deaths. The third one about the Latin American safety guidelines, and the fourth about some catastrophic events with very poor neurological outcomes after general anesthesia in Venezuelan children in a few cases in Latin America. The first issue is about Mexico's tragedy. They started in 2023, and it started that they identified a number of cases in which patients died after spinal and epidural anesthesias. And it was a real major catastrophe. There were hundreds of patients affected, and more than 100 patients died. There was this had a very, very significant impact. Of course, there were anesthesiologists that were in Mexico. It works a little different from most of the places in the world, in some countries in Latin America, regarding the issues of medical malpractice. Is not, specifically something which is civil processes, but penal. So there were anesthesiologists that were jailed and prosecuted as a homicide, and things, went really crazy. So when the analysis were done, the hospitals were closed, something like 50 or 80 hospitals were closed in different states in Mexico. There were analyses that were performed, and it was identified that there was, in most of the cases, there was a fungal infection in these cases. And the Mexican Society of Anesthesiologists configured a task force to try to analyze the processes. The basic summary of this was published by the APSF this year. We had there, the first one is a Mexican physician, and there's Dr. Paul Barash and Adrian Gelb from the US. Dr. Van Sundert from Australia, and other Mexican colleagues. They did all this analysis. It was a really major effort because they had this task force met with the physicians, met with administrative individuals, met with the patients, met with the relatives of patients, the casualties. So it was a major work done by this task force, and they finally, like I said, they identified that the problem was related to contamination, and they will develop some analysis. And the key findings that they had significant issues regarding problems with individual vigilance, weak clinical governance, poor regulation of medication handling. All these issues were really important to understand more or less the dynamics about whether, because the main issue about us in the safety business in anesthesia is to prevent this from happening. So as the safety committee in Latin America, we did a survey among colleagues in Latin America. We had 216 responses. These are the countries basically that answered our survey. We asked about adjuvants because the main concern was that somehow the fungi got into the mixtures that the colleagues were using. So we asked about how often did the colleagues use the different adjuvants. So we have all these adjuvants that were being used, most commonly fentanyl, also for epidural and from spinal. Asking people what kind of issues that they had figured out. I mean, they have observed over the years, but most of them, the problem was related to dosage. Others making a mistake of what medication they administered, precipitation, and very few had any complications regarding untoward effects like infections or something like that. Very, very few. But when I asked about all these things, one of the complications, one of the issues that I was really surprised was to find out that some of the colleagues answered, there was one response of reusing spinal needles, which was something that I found quite surprising that even happened. And I said, well, this is only 216 responses from a universe of something like 50 or 60,000 anesthesiologists in Latin America. I also asked about if they have heard about all these horrible complications, and of course, everybody had some experience around this. So the issues around Mexico was that there were a loose compliance of regulations. In Mexico, colleagues transported medications from one hospital to another. They used multi-dose vials to dilute medications for neuraxial anesthesia. They used multi-use elements to clean up prep the patients. So all these things were really deeply concerning. The other issue that we have had this year is another tragedy in Argentina, in which one company that manufactured, one of the main providers of fentanyl in the country, had horrible manufacturing conditions, and they had two bacteria that contaminated a huge batch of fentanyl ampules, and right now there's more than 100 people have died because of the contamination of fentanyl in Argentina. And as I said, when the authorities went back and looked up at the manufacturing standards of this company, they were really shocking. And it's been a major issue as this is, I mean, this is out of anybody's imagination that you can have something like 100,000 ampules of fentanyl with bacteria. So, of course, patients who used it, colleagues who used it for neuraxial or even intravenous use had very tragic events with the deaths of many of these patients. The third item I wanted to talk about was the minimal standards for anesthesia practice. In Latin America, a few years ago, we did some analysis of which countries had some guidelines. Overall, only 4 countries out of the 23 class countries, membership countries, have had guidelines. Colombia was the first one in 1992. And Brazil follow up a few years later. And Mexico has some of them from 2007, 1998, and then Peru in 2003. So one of the efforts that we strive to look forward for these guidelines was to have Latin American guidelines for the countries basically that did not have them. An important issue around guidelines in Latin America, and probably would apply to most middle or lower income countries in the world, is that different from high income countries, in the high income countries, these guidelines have been devised as basically consensus among their members, and it reflects the standard of care, which is different from middle income or low income countries like in Colombia. When we wrote the first standards in 1992, we included pulse oximetry at a period of time in which penetration of pulse oximetry was something like 1 or 2% in the ORs in the country. So we made it mandatory. So the standards in Latin America push forward to improve the standard of care. Different from what I said from high-income countries. So this was a major effort because some societies were very concerned about the impact that the liability that these would generate if enacted. And finally, after 5 years of work and lobbying among the Latin American societies, last week in the General Assembly of the Latin American Confederation of Societies of Anesthesiologists, these minimal standards were accepted and approved last Saturday, actually 1 week ago, for Latin America. Basically, our standards reflect what is available for most standards around the world. We have basically, I would simplify it to two main differences. One is that we have admission, and this we developed them in Colombia, we have admission criteria for the PACU. Why? Because different from the high-income countries where PACU staffing includes very highly qualified personnel, in Latin America and in low and middle and low-income countries, we do not have that. So we have to establish a minimal of an Aldrete score of 8 or more in order to accept them into the PACU area. So that's a major difference from the standards anywhere in the world. We adopted them in Colombia in 1998, in the first revision that we had, and we finally had them in place for Latin America. And the other one related to the issue that we have faced in Mexico, and now the issue that we have in Argentina, is that we have written explicit recommendations on medication safety, which clearly has been a major source of headaches and tragedy in the Latin America. And the last item I want to discuss is about the issue about tragedy that we have had of very surprising scenarios in which children of offspring of Venezuelan mothers, that's really the amazing thing, have died unexpectedly. So in Venezuela, in Spain, actually in Germany, they had another one who was a Venezuelan, from a Venezuelan mother. These kids this number of cases that at this point, we believe that we have at least 20 cases where patients who had no previous medical conditions to be concerned of and developed catastrophic neurological outcomes, and most of them died. A few were severely discapacitated afterwards. And in a few of them, there has been a genetic analysis performed, and it was found out that there was a very new mitochondrial genetic abnormality found, and that explained that something really horrible. Basically, the children that have had we have information about this, have had basal ganglia infarcts, and they developed this really catastrophic scenarios. We have had in Colombia at least 4. In Chile, they had 6 cases. In Venezuela, they have a couple of them. Because of the political implications there, there's been kind of a hush-hush issue around this. There's been an effort in Spain to study a cohort of 8 patients. So overall, I think we have already around 20. There was a statement made by the SPA and the ASA a few weeks ago around this. The only publication that we have, actually this is a pre-publication, is from a case in Colombia in which in a very important hospital in Colombia, they did the genetic analysis because they began the lawsuit, and so the genetic analysis, and so they found out this mitochondrial abnormality like in the other cases I described. So in Latin America, the Safety Committee, we wrote a statement around these, and basically the issue that we have is that it is really surprising that it's related to only the children that have been affected have had mothers of Venezuelan origin. That's the only common factor among these children. So in conclusion, we have faced major safety challenges. We have made efforts to analyze the situations. We have a problem regarding the political and the penal consequences around these. We have the new LATAM guidelines that will help us prevent some of these tragedies from occurring again. And you're well invited to the World Congress of Anesthesia, the WFSA, next year. Thank you.
Okay, so we're gonna move on to our next speaker here. I'll set it up for Dr. Bure here. And that looks good.
Yes. Yeah, good morning, everyone, and thanks for inviting me. I think what Pedro points out is one of the most important lessons. We have to know what happens, and we have to communicate to each other. Because, as you said, we were also involved by a colleague from Colombia, together with our colleagues from Spain, about the last case you presented. It's a couple of patients there, a couple of patients there. That means safety means, in our opinion, communication. Make it visible, help us to learn from each other. Okay, try it that way. These are my conflicts of interests. And today we are talking mainly about the Helsinki Declaration 2025, which is called, in modern language, Helsinki Declaration 2.0. Europe is approximately a bit more than 40 national societies. So we started to come up together to a, let's say, common ground of patient safety in the mid of the 90s, because we also have a couple of organizations, and we succeeded to get it done at the first time in 2010. So in 2010, we signed the declaration at the Congress in Helsinki, logically, where we defined what we as anesthesiologists think should be done to guarantee safe perioperative care. The next big step forward was in 2025, where we again, after I think 3 years of discussion, came to the version 2.0 of this declaration. And the story behind the declaration is quite simple. In Europe, we have the European Board of Anesthesiology, which is the owner of the declaration, and we have the European Society of Anesthesiology, which is the organization which tries to help us to implement things. So, in fact, we started with the declaration, and then we realized that a couple of countries implemented them quite well, but approximately 25 not well. Therefore, we thought, okay, we have to do a couple of things to help those which had problems to implement patient safety rules on a more structured basis. And the main reason to not implement safety was shortage of staff and money. There was no, let's say, argument against that declaration. It was just these two things. And there was a slight difference from north to south, from west to eastern in Europe, you can imagine. So over the upcoming years, we built up a community of safety ambassadors throughout Europe, which helps implementations. Besides what Pedro already said, we have to know, we have to be aware, you have to build up a network of people dedicated to patient safety. Ideally in every country, in every hospital, in every let's say, anesthesia group, wherever you work in, independent of it's private or public, if it's in the east, in the west, in the north, or in the south. This is something which we take into account over the years, and we learned a lot. The Helsinki Declaration was accepted, the first version, by a lot of anesthesia communities in a lot of different countries, and we're extremely happy, because this helps us to communicate with each other on a global basis. And I think momentarily we are in the process of ratification of the Helsinki Declaration 2.0 They just published it a couple of months ago, and a lot of societies will do so. There were also a couple of publications around it, because what we see is our duty is to check, okay, if we offer something to the community of anesthesiologists, does it result in change in practice? Does it result in change of procedures, etc., etc.? So I think it's a very good instrument, these declarations, to help us to come together, to learn from each other, to build up something which is a basic, it's a fundament. And we always had that colleagues from, let's say, the highly educated European countries saying this is not enough. But we also always try to find a compromise between all of our communities. And I think we can be quite happy. The other thing is what we did not know when we started. In terms of health legislation in Europe, you have one period pre and one post-COVID. Pre-COVID, everything was national. Post-COVID, nearly everything is European. In other words, what we did with this declaration, we produced a law without trying to do so. Because a lot of countries said, okay, if the European community of professionals decide that this is the way we work, then we expect that hospitals and organizations act accordingly, which was not, let's say, quite common more than 10 years ago. This year, we decided to have a couple of new agreements and new requirements. These are the two values. An agreement is an agreement, and then a requirement is needed all the time. So we spend a lot of energy to align with what the global anesthesia community is thinking, and particularly the WFSA. There were slight differences, and we put them out. And it's a lot more about patients' rights than we had in 2010. If something happens, we need to stay connected with our patients as professionals. So we also put a lot of energy in saying sorry, working together, and training our community to be able to do so, to stay open and transparent in terms of complications. There's a lot of evolution. There are a lot of papers about artificial intelligence and the possibilities we probably have in that environment. And we also know that in a couple of countries in Europe, the pre-op clinics are run by artificial intelligence algorithms now. Do we need to see a patient or not? And we say, okay, whenever you implement these, which is maybe very helpful in predicting perioperative risk, be careful. Take your time, evaluate it appropriately. As we all know, there are a lot of companies now on the market which offer you to see double the patients in half of the time by using the AI algorithm, which is in their app. So we take some time to do so. We think that we need research based on cases, research based on processes, research based on structures. So we actively put a lot of energy, and most likely next year also a grant into patient safety research, because it's relatively difficult to get it funded from other sources. And I think we as a community will contribute from these things. So independent national bodies in the Netherlands, it's quite normal. We have a national body for safety. And this holds true for anesthesiology, but also for traffic, but also for whatever you can imagine. This is not the case in all European countries. So we work to get that implemented. In particular, as a lot of the bodies in a couple of countries are quite political and not independent. So this will be a major step forward if it works out. And at the end of the day, there is a totally difference in culture how to deal with medical thoughts. In some countries, you have a culture which allows to discuss the thoughts, but there are also other countries in Europe where people go to jail, and it's criminalized. And it's the other way around, that you as a doctor need to prove that this is a fault and nothing else. Last but not least, speak up. We know there are a couple of structures in departments and in hospitals which don't allow an open culture. So we try to promote that, and as you all know, this is not one of the most easiest part of such a declaration. What we are confronted with is also in Europe with a severe shortage of people which are willing to work in healthcare, resulting in severe fatigue, resulting in policies of hospitals which does not allow to work appropriately in terms of safety. We did a couple of research from the European Society. We will continue that because we realize that this is a major concern for safety. And I know that compared to other parts of the world, the European working conditions are probably much better. Nevertheless, we do have a lot of cases, a lot of close claims and everything else you can imagine, which is purely related to fatigue. So fight fatigue will be one of the major topics for the European Society in the upcoming years. So we would love to have in all institutions policies which are to some extent form the basis of well-being of caregivers. Because this is also something which will take us a couple of years to install that, but nevertheless, we are in the meantime able at the European level and at the European Commission able to put a lot of pressure on healthcare givers which did not comply with, let's say, staff well-being. And this helps most likely, but we have to put that pressure still on the healthcare givers. And environmental sustainability should be one of our targets, as you all know. These are the agreements. Let's say requirements are one step harder or tougher or in fact more binding. And as you can imagine, and I told you a couple of minutes ago, the declaration at a certain moment becomes a sort of law. So we took a lot of energy and time and a lot of meetings, a lot of emails and anything else to define that appropriately. To not overstretch a couple of colleagues in a couple of countries. Nevertheless, we are talking about perioperative care, perioperative anesthesia-directed care, which in Europe differs a bit from the States because also the ICU business is run for 80% by anesthesia departments, which is different to the US. So we are talking about the whole process, and in the 2010 declaration we were much more related to the anesthesia room itself. Second, we realized that a lot of the things we are doing, a lot of our patients nowadays are not in the operating areas, but in the intervention themes, in the diagnostic areas, etc. So we actively expanded our space from the operating theater to every place we are practicing. And in other words, all these people have the same right of preoperative evaluation, monitoring, recovery, etc. To make you understand, it's a bit different from country to country. In the Netherlands, no patient is allowed to be planned for surgery without anesthesia agreement. So no surgeon, the other way around, is allowed to plan any patient without anesthesia agreement. And this is also true for the Scandinavian countries. But in a lot of other countries, it's always the other way around. So we try to balance it a bit. Well, the other thing is the multidisciplinary approach. We heard a bit about it in the last hours yesterday in our CP Med meeting. It was an important part, and I think we will talk about that in the upcoming days. In our opinion, that's the European view. Anesthesia is a bit the last holistic specialty in the hospital. So we have the best oversight about patients. We know their flows, and we also see at least the severe complications. That means we actively think that multidisciplinary meetings and multidisciplinary decision-making is a prerequisite for patient safety in the upcoming years. This is an enormous burden of work. In my own department in Utrecht, we have anesthesia-driven multidisciplinary meetings, approximately 25, 26 a week, without pain, without intensive care, pure for anesthesia. So it's an enormous amount of work, but we still think that it is encouraged. Pedro already talked about medication, because besides contamination, medication errors by false syringes, etc., is a common problem. This still gets a bit harder recommendation than a couple of years. So again, staff well-being. We've realized that a couple of things like fire prevention, emergency evacuation, power and gas supply failures, etc., are not very well and done and implemented in Europe, in every country. So we thought it makes a lot of sense to put some energy in that. And the serious incident management is something which requires our attention. And as I said, we try to stay as close with the suggestions of the WFSA. Every department should know what happens in the department every year. So we really encourage all departments of anesthesia to come up with an annual report. We will offer some support in that, because we realize that this is different from country to country, including what is documented in the safe surgery checklists, etc. And we will also, from the European Society, help the departments and the countries to analyze these data. And, well, we think that it's the national and local audit of safe practice, independent investigations, the ability to have root cause analysis is quite helpful. So what has happened between 2010 and 25, we put much more energy on the perioperative period, on the, let's say, the anesthesiologist as gatekeeper and coordinator of care for patients. We will put some more energy in the future also into RI. And we think that it's an ongoing process. So, as I said, we had a journey. What we realized in the, let's say, early post-operative period is that we have to offer a lot of things for our community. So we have a whole ambassadors program in patient safety throughout Europe. In the meantime, we developed that, and it's already established. Basic, advanced, expert. And in 2025, we're quite happy to see the first ambassadors, and I see that it's a lot of people interested in that. We raise awareness, we create and share content, which is important for society. We try to help to build up the network of experts. We will also try to help to analyze databases, and we will try to expand it. Thank you. Am I on time?
Thank you both. I mean, these are incredible. So we got our final speaker here. I'll just set it up for Dr. Connolly here, and then we'll hopefully have some time for Q&A.
Yes, thanks so much for inviting me to this panel. I might have a little easier job because I don't represent multiple countries, but I was asked to talk about the American Society of Anesthesiologists initiatives in patient safety. Let me see how this slides work here. Did it advance? No, there we go. Okay, so my goals is to just look at some of the ASA initiatives in patient safety, specifically the Anesthesia Patient Safety Foundation, Closed Claims Project, our practice parameters, and our anesthesia incident reporting system. Some of our ASA initiatives in quality, specifically the Anesthesia Quality Institute and NACOR. Understand a little bit about our value-based programs in the United States, and understand we have a little different programs here in the United States on how we get paid through Medicare with our quality payment programs, and just talk about the challenges that we have with our regulatory environment and the burdens that it kind of places on our practitioners. So I'm going to take you back a little bit, way back into 1999. The Institute of Medicine published a book called To Err is Human, Building a Safer Healthcare System. It was estimated in 1999 that as many as 98,000 people died in any given year from medical errors. Well, it's probably a lot more than that, right? But in this book, they called out that anesthesia is an area with very impressive improvements in safety, and where safety steps have been made. 20 years later, a book was published, Still Not Safe. And once again, had we made big strides in building a safer healthcare system in the United States? Again, they called out anesthesiology as the one area of healthcare that's generally acknowledged to have achieved an order of magnitude of improvements in patient safety. So I want to take you back to what was going on in the 1980s. It was the anesthesia-related mortality rates in the U.S. were about 2 deaths per 10,000 anesthetics at that time. And the medical malpractice community was, very robust. It was very expensive to get malpractice insurance. And so it was in 1984 under Dr. Pierce, who was then the president of the American Society of Anesthesiologists, who constituted a new ASA Standing Committee on Safety and Risk Management, emphasizing the need to address the causes of patient injury. That led to formation of two things. One, the Closed Claim Project, which was in collaboration with the University of Washington in 1985, and the Anesthesia Patient Safety Foundation in 1985 as well. It also led to the development of some of our standards. Our first standards were released in 1987 for monitoring. It wasn't, though, until 1989 that pulse oximetry was added as one of our standards, and end-tidal CO2 as a standard in 1991. The Committee on Practice Parameters started developing practice guidelines and recommendations, and there was widespread adoption of a lot of our standards and practice guidelines throughout the U.S. We had improved monitoring techniques as well as a lot of industry investments, focusing on understanding the factors that contributed to error and trying to design more safer systems and prevent mishaps from occurring. We also introduced, just probably within the last 20 years, patient optimization strategies. And what we talked about yesterday at CP Med was, all of the organizations that are really bought into optimizing patients for a safer outcome in surgery. Also, we have the Anesthesia Quality and Patient Safety meeting, which is now part of our ADVANCE, which is the business meeting of the ASA. So a lot of things going on. Just to touch a little bit about our ASA practice parameters. Again, our standards were developed in 1985-86. They're not evidence-based, they're consensus-based. But it sets a minimum baseline for safe practice of all anesthesia cases that occur in the U.S. And those, there's only 3. Now there's probably going to be 4, and that's the ethical practice of anesthesia too, which I'm not going to get into here, but standards for basic anesthesia monitoring, basic standards for pre-anesthesia care, standards for post-anesthesia care, like we had talked about. The Agency for Healthcare Policy and Research was created in about 1989, and they urged all medical organizations to develop evidence-based guidelines, and it was under Dr. Ahrens where our practice parameters and our practice guidelines started. They're recommendations for safe practice. They're not requirements, and there is a disclaimer in all of our practice guidelines because we can't guarantee a specific outcome based on a guideline that we put out. They're highly evidence-based, and they get periodic reviews. Right now we have 14 guidelines that are available, and you can see them on the ASA website. If the scientific evidence is not sufficient to develop a guideline or an evidence-based parameter, they're released as advisories. And we have about 10 advisories available to us. And the last practice parameter we have is a ton of statements, like 80 statements that are generated through some of our ASA committees, and they need to be approved by our ASA House of Delegates. They are the weakest parameters overall. The Anesthesia Patient Safety Foundation was already mentioned here. It's a worldwide organization, reaches a lot of countries. It was founded, it's a foundation of the ASA. It was founded in 1985, and it really is a multidisciplinary team of practitioners, CRNAs, nurses, CAAs, anesthesiologists, and lawyers actually, and general public who sit on the Anesthesia Patient Safety Foundation board. They address a lot of issues, harm related to medication errors, just like what you've already heard from other countries, inadequate monitoring, especially for our sedation cases. We as well are experiencing poorly designed non-operating room environments or anesthetics that are occurring in areas that are suboptimal in space and in lighting. Culture of safety, just like Wolfgang talked about, is really huge. Team dynamics and who is working within your team. JAMA published an article in 2023, just a couple of years ago, the association between familiarity of the surgeon and anesthesiologist dyad and post-op patient outcomes in complex GI cancer surgeries. And what they found is that for every additional time that there's a unique surgeon, anesthesiologist, dyad working together, the odds of a 90-day mortality or major morbidity decreases by 5%. That's significant. So we need to promote teams to work together for better and safe patient care because it's about the team working together. You shouldn't have all of the unique individual teams all the time. Again, to care is human. We are human and we're taking care of patients. So clinician safety, as you heard a little bit about, is huge. Addressing fatigue and burnout. The Anesthesia Patient Safety Foundation also holds a Stolting Conference every year, and this was about the care of maternal fetal medicine specifically, but every year they have a very specific topic that they address in depth. We also have the Anesthesia Quality Institute. It's the home for 3 of our ASA registries. The Closed Claim Registry, which originally was founded and run through the University of Washington, is now located and housed under the Anesthesia Quality Institute. We also have the Anesthesia Incident Reporting System, or the AIRS, that kind of serves as our canary in the coal mine. It lets us know if something is happening or occurring across the country. And one example specifically is multiple reports were coming in on air embolisms that were occurring after or during ERCPs. And so we're able to get a good look at what was going on very early and send out a message through the whole community, either through, our monthly journal, The Monitor. Also, we have the National Anesthesia Quality Outcomes Registry, or NAQOR. This is a CMS or a Medicare-specific designated clinical data registry. And this data registry is one of the few portals for reporting quality metrics on a national level into our Medicare quality payment program. It is also used for local quality data tracking, and we are engaging right now Epic into working with us for more robust electronic data through the Anesthesia Community Registry. I would just want to briefly touch on this, and that's value-based programs in the U.S. It might be a little different in other countries of the world. We're highly regulated and run by legislation. So legislation in 2008 and the Affordable Care Act in 2010 really set the stage for hospital value-based purchasing programs. It wasn't until 2015 when MACRA, which is an acronym, was passed into law, but MACRA hold healthcare clinicians accountable for quality and cost of care, very similar to what they did with hospitals way back in the early 2010s. The act really began in 2017 with payment adjustments to our payments through Medicare in 2019. And this is basically a big overview of what the quality payment program is. Eligible clinicians, there's terminologies around this that really need to participate in the quality program, has to follow certain rules to be able to do this, but most anesthesiologists really don't fall into an eligible clinician status. But you can participate in the quality program here in the United States by two arms, really. Merit-based incentive programs where you basically report your quality and your improvement activities, or through an advanced APM through an accountable care organization. Most anesthesiologists in the U.S. participate either in very large groups or through an accountable care organization. And you have to meet a certain point leverage, and it's a Hunger Games mentality where if you exceed the number of points, then you get an uptick in how much that you're able to adjust your payments through Medicare. So I just want to point this out because those in the room who are U.S.-based, what does that mean to us through Medicare? What's the financial benefit? The bottom graph table here actually shows that the most positive adjustment that you can get for 2025, which is this year, was 2.15%, which is a whole 43 cents on your Medicare conversion payment. The median, though, if you look mean and median, that's more like 0.59% or 12 cents, adjustment. So it's not huge. In the future, what we're seeing is that if you are part of a qualified APM participant, that will be built into your conversion factors in how you get paid through Medicare. It's a little different than what you're experiencing, and I'm sure in the other countries in the world. So basically, ASA and others in the medical community, we've argued that these are really small incentives, and they really are insufficient to cover the cost of even participating in the quality payment programs, unless you can scale to size, unless you have a very huge practice that you can do that, or if you partner with your hospital accountable care organization to be able to do that. And these are some of our measures that you can use to submit your quality measures. We have here 13 and an additional 5 if you're not reporting through a qualified clinical data registry, but just with a qualified registry. And we're moving to more of a MIPS value pathway patient experience kind of scenario by 2027. So what are some of our initiatives in a highly regulatory world, it's really a lot of regulatory burden reduction. You know, how can we reduce the burden that that is imposed on us on all these regulations in the United States? We talk about interoperability, patient access to records, information blocking. There's some mandatory models that are being run through the Center for Medicare and Medicaid Services that are novel, that are mandatory. Prior authorization's a big thing that we deal with in the U.S. as well. Conditions of participation, physician supervision, those are also things that we discuss. We respond often to a lot of proposed rules that are released, the Medicare physician fee schedule. We have a time whenever we can write back or put our comments into CMS for those changes. They change every year, as does the quality payment program proposed rule. We deal with a lot of private payer concerns, United Healthcare denying payments for physical status modifiers or some of our other qualifying circumstances, out-of-network issues, shoving practitioners out of network and paying them less, capping payments on anesthesia time. But as I was putting this all together, I'm like, this is highly regulatory. A lot of effort goes into this. Are our anesthesia quality metrics that we run and our participation, is it making a difference in outcomes? I'd like your opinion on that. Is it making a difference in outcomes? Thank you. Well, yeah, thank you. Yeah, you can contact me anytime. Thanks.
Well, excellent. I want to thank our speakers for these really informative presentations. So we have about 5 minutes or so for questions. So would you like to maybe we'll just kind of see who, I think probably be easier if people just came up to the microphone. If you have any questions for any of our speakers, please feel free.
Hi, whoops. God, it's very good getting old. So, Dr. Ibarra, I've got 2 questions for you. One is, how were the spinal needles being cleaned? Because, like, when I was a kid, we always reused spinal needles. Had to sharpen them. The other question is the mitochondrial mutations. Is there any thought that's related to the spread of mosquito-borne diseases in the area?
Okay, regarding the survey that we did, and we had one response with somebody who reused spinal needles. We did not ask how they did it, but that was for myself. I mean, when I was reviewing the answers, it was shocking, actually, really shocking. Yeah, this is really shocking. But regarding the mitochondrial issues, it is important to realize that when we went over the literature for mitochondrial diseases, we found out that basically no genetic abnormalities in these mitochondrial diseases were really related to significant anesthetic outcomes. Whereas these 20 or so kids that died had catastrophic events. So the mutation seems to be a completely different one from the one reported in the literature. Actually, the pre-publication paper I showed from the Colombian team who did these genetic analysis is being submitted at this point to your journal. And there's this Spanish group that is trying to work into doing a very more in-depth analysis of this, and we expect that we will have some more information within 2 or 3 years. The speculation that we have is that maybe in some area in Venezuela, there was some environmental issue that affected the women who born this children afterwards. That's the speculation that we have, because actually the Venezuelan society was deeply annoyed about being pointing out Venezuelan children as
So my question is also about this terrible mitochondrial-related deaths. And I wonder if you know Phil Morgan and Marge Sedensky at University of Washington. Phil Morgan's a pediatric anesthesiologist and anesthetic pharmacologist, and he had identified multiple mutations in children in the mitochondrial genes that related to deaths, very much like that sounded like what you said. And it was due to extreme anesthetic sensitivity, like 10x sensitivity.
I've not seen those reports. I will
Yeah.
get that information because we found out all the literature in mitochondrial diseases, and
Yeah.
actually in all the cohorts that have been described, there's been not one single death. That was
Okay.
really shocking. So
Okay.
having these
Phil Morgan has a whole cohort. Yeah. Okay, we'll talk.
It's very, very interesting. Yeah. Any other questions? I have a question just thinking about the Helsinki Declaration. I know there's a requirement for an annual report, but just thinking about specific metrics and reporting, is this something that's part of the, certainly a question for both of you, sort of part of the agreement that you made? Are there some things that you absolutely want people to report? Obviously, there's some challenges with that. Collecting data, EHR, obviously has not been universally implemented in many parts of the world. I'm just curious in the last remaining few minutes that we have. Maybe I'll ask you first, Professor Burr, and then.
Yeah, well, what we said is there needs to be at least a complication registry. That's the basis.
Right.
And I think nearly every national society has that, and just document it, to make it visible, because, as you said beautifully, we all deal with rare complications, but we need to know these rare complications. That's one thing. The other thing is that what we actively acknowledge is to figure out a couple of parameters for, let's say, the role of pre-op assessment, because when you analyze cases, you sometimes think, okay, when we have thought about these patients a bit more on beforehand, then the risk can be reduced. And this is at the moment a point of discussion. The last but least, what you heard, we cannot come up with a declaration on, let's say, on our behavior as anesthesiologists, because it's much different. We know centers which know precisely how many minutes a patient has a blood pressure below 65 mean per anesthesiologist, which can deliver these numbers, but which is maybe something of interest, but you cannot bring that into any.
You can't standardize it, at this point.
And the second question is, does that have any effect on outcome?
Well, that's always.
And the last but not least point, in the Netherlands we have a couple of anesthesia-related registries, and we're looking at our patients for 1 year, because we've seen that a lot of things don't happen during the primary in-hospital stay, but a lot of, in particular, pain-related complications, neurological complications, which are not so major, we detect them after 30 days or 6 months instead of being, and that's the biggest problem, the biggest challenge we face.
Wonderful. Well, I want to say one thing, and then I know there's another panel coming here.
Colombian Society of Anesthesia has on the side malpractice defense fund, and with that, we have collected some cases like in the Philippines. One of the issues, for example, was the mix-up of tranexamic acid and bupivacaine. So there was this mix-up, and we had 2 patients who died, one who got severe disability. So as the safety committee, we talked with the main provider
Wow, that's great. Yeah, I didn't know that. Yeah. Wonderful. Well, thank you. Yeah, I know there's another panel coming up, but hopefully the speakers will be available for a few minutes. I do have to run to another lecture I'm giving at 11, but thank you so much. Thank you for attending. Thank you.